give me a pleasure to present Dr. Roy Vergis. He's going to give us a talk about artificial intelligence in medicine and oncology, challenges and promises. He's an associate partner, Watson Health Consulting Global Clinic. He works in IBM Watson Health, and he is a leader in transformative technologies. He's an oncologist, which is very glad to see, clinical oncologists, surgeons enrolling in artificial intelligence. And he's as well as an advisor to the World Health Organization and expert in digital health at the WHO. Without further delay, we are looking forward for your presentation.
Thank you very much, Professor Samar, and thank you very much to the organizers for inviting me to this talk. Let me start by sharing my screen. I hope you can see my screen.
Yes, we can.
Great. I'll just put it into slideshow. So yes, as I was introduced, I hold. I wear different hats at the same time. But I wanted to start by actually thanking the organizers for obviously for the invitation, but also for the timing of the invite. So a couple of months ago, I was invited to a remote virtual session in Paris. And I thank the organizers for inviting me because of the fact that actually my hair had been growing pretty wild. And short of asking my wife or my daughter to cut my hair or taking matters into my own hand, I was looking quite unpresentable. And again, as Nadine will attest, we're in the middle of a lockdown in England again. And I managed to get my hair cut in the nick of time. But joking aside, what I was trying to say was that now, more than ever before, this current pandemic has shone a light on how critical digital transformation is to healthcare, including in oncology. We are living through very challenging and uncertain times. However, it's encouraging to see, from accelerating drug discovery with supercomputers to providing trusted information using chatbots, how technology is transforming our ability to tackle this health crisis. So a little bit about myself. I was secretly pleased and rather amused to see that on the list of the speakers in the conference website, I was credited with belonging to the Pixar Animation Studio, the company that gave us Toy Story and Up, and has been a pioneer in innovation technology. So, like I said, I was quite chuffed to see that connection. But no, to disappoint those of you who may have noticed that, I'm not part of Pixar. I'm an oncologist by background, based in London, and I have been for more than 20 years now. I worked at the Royal Marsden Hospital in London and Sutton for more than 10 years, and I spent 3 years in the lab at the Institute of Cancer Research doing research on hypoxia and prostate cancer. I've been a consultant oncologist in Kent, among other places, and most recently at Mount Vernon Cancer Centre in North London, where I still practice as an honorary consultant before I joined IBM Watson Health. So I still see patients, and my area of expertise is prostate and skin cancer and lymphomas. So in addition to that, as I was introduced, I also advise the WHO on digital health. So that's about myself. So let me just get to the talk, if I may. So what I wanted to do today was to speak on, in general, on artificial intelligence in medicine and oncology. Talk about the opportunities, talk about the challenges, where we are now, the reality, if you will, and finally, what is the future promise of AI in medicine and oncology. I'd also like to spend some time and focus on some of the challenges that we have faced in IBM Watson Health with clinical decision support, and highlight positives. So as you can see, I've used PowerPoint for this presentation, and you can already see that the Office Intelligence Services are using a form of AI, if you will, to suggest different design ideas for my slides. So I was quite impressed by that off the bat. All right, so if we were sitting together in person at Riyadh, I would have asked for a show of hands or a voting system and asked 3 questions of the participants. How many of you think that innovation technology is good for medicine and oncology? And how many of you think it's bad? And the big question, how many of you think that innovation in technology like AI is going to make clinicians redundant, perhaps lose your jobs, make you obsolete? So that would have been a sort of pre-presentation question or poll question that I would have wanted to ask. So this is a very powerful image, isn't it? The rise of the machines and the end of humanity as we know it. When you think of AI, I'm sure some of you can relate to this image and perhaps think of images from some of our blockbuster Hollywood science fiction movies. The Terminator series and the Minority Report come to mind. Pop quiz, again, I would have asked the audience, anyone knows what this is? I'll give you a clue. It was invented in France. And in the interest of time, I'll cut to the chase and say this was the first stethoscope that was invented by a French gentleman. And we still use a variation of it today in our clinical practice. What many of you perhaps don't know is that when it was first used, there was quite a lot of criticism, fear, and taboo associated with it. And now for most healthcare professionals, it is part and parcel of our armory in medical practice, if you will. I still remember this image on the left. When my brother was studying for his master's in aerospace and computer sciences in the early 90s, he had one of these. It was an IBM PS1 with an optional 30 MB hard disk and 512 KB of memory. So just let that sink in. And cut to last year, and you can see the image on the right, and you have powerful quantum computers like the IBM's Q System 1, which is a 20-qubit computer. Extremely powerful quantum processors and immense processing power as well. Very good computational power. So artificial intelligence was first used in the 1950s with the goal of replicating the human mind as to perform tasks such as recognition, interpretation, reasoning, and conversing with the acuity and influence typically attributed to humans. Machine intelligence, which is a more focused area of AI, which is sometimes referred to as augmented intelligence, aims to augment the human capabilities for which the human mind tends to reach its limits. So it excels in certain roles that humans are probably not necessarily the best at. And the AI role that IBM has played was in Watson, creating Watson, which was most famously known for winning against human experts in knowledge and strategy games such as chess. And you've heard of other similar tools that Google and DeepMind, etc., have used. So AI is not new. However, the recent improvements in memory and ability to process and crunch vast amounts of data has meant an explosion of AI-based systems now. And you heard Nadine talking about some of the work that has been done in the field of surgery, but so also in many other aspects of medicine and indeed oncology. So let me spend a few minutes to talk about these three different terms. So when we talk about artificial intelligence, we mean any technique that enables computers to mimic human intelligence. And then you progress to machine learning, which is a subset of AI that includes techniques that enable machines to improve at tasks with experience, and also includes deep learning, which is a subset of machine learning that is composed of algorithms that permit software to train itself to perform tasks. So if you will, the high end of what we like to call as AI. And you can see that, if you will, the timeline here, which is where it started in the 1960s. It's not really new, and then progressing into the sort of early 2000s and where we are right now. So what are the challenges in medicine right now? You can already see that there is this explosion of data that we're generating, whether we talk about social media, emails, apps, a lot of health data, measurements of blood pressure and other measurements. And we kind of here, if you can see where I'm pointing, and all this is only going to increase and generate more data. So it would be useful to make sense of this and draw some valid conclusions. And currently we're limited in how we can process this vast amount of health information. And we will need to rely on help and computing power. So there's an obvious gap here. And we're still in the early days. There's a lot more that's coming. So again, if I were to move to the next slide, which is the challenges. So you can see that, as I explained earlier on, the amount of health-related data that's generated in a lifetime is huge. Medical data is expected to double every 73 days as we speak, and each person will generate enough health data in their lifetime to fill millions of books. It's impossible for physicians to keep up with this growing amount of information. A lot of the health data, unfortunately, is unstructured and therefore invisible. Physician shortage and burnout, which is a key question. We've seen that with COVID-19, the amount of hours that physicians are working, and obviously the risk of burnout as well. And really the amount of time of reading that one would need to keep up with all this data with. So the exponential increase in cancer knowledge, coupled with the speed of advances, is creating an extremely significant knowledge gap for practicing physicians, oncologists, etc. And globally, if you look at it, you can see this is a slide that shows the amount of the scale of the problem. It's kind of what I alluded to earlier on, but you can see that it is not an insignificant issue here. If I were to move to the sort of impact on doctors, so last year at an oncology conference, I was speaking to a panel of doctors. It was based out of India, and we were talking about what are the main pain points, and everyone agreed that the EMR was a significant sort of pain point. And you can think about sort of going through notes. We now have electronic medical records and electronic health records, but essentially the amount of time that a doctor spends with a patient is far reduced when it's supposed to be helping us, really. So there's a few areas that clearly we can try and improve on and speed up the process. It's very interesting that that there's this connection here with Guy's and St. Thomas's, because we did a pilot study on the use of clinical decision support in the context of breast cancer MDT. So anything that can speed up the process will be beneficial for all of us and ultimately the patients. Who can keep up? Does anyone recognize this? This is exactly what clinic looked like, at least when I started training. And my personal records actually were the size of several of these folders, which I had to sometimes carry to my appointments when I was a consultant in Kent. And I still remember, my secretary coordinating a stroller suitcase full of these patient notes, which I then used to take to a peripheral clinic. And then, of course, coupled with that, the proliferation of medical literature is another side of the coin. Altogether, there is too much data for physicians and oncologists to consume and keep up with. The amount of data explosion, again, in some ways is a repetition, but it just highlights once again the scale and the importance of the challenges that we are facing in our clinical practice. This obviously is very much linked to the cancer crisis. So you can see that there is an increased incidence. Typically, and I haven't worked with the WHO, I'm very aware of this, almost more than 2/3 of the global cancer deaths occur in low and middle income groups. And obviously the costs are very significant. And clearly the dearth of medical data, keeping up with that is another significant aspect as well. Again, a repetition, if you will, but again, I just put this in to just highlight the amount of, or the scale of the challenge that we're facing, as well as risks such as the cost of data breach, the risk of clinical and data error, physician burnout, etc. I think we have to come back again. Nadine mentioned very clearly, it's all about our patients. You have to think about this in the context of what are the patient goals and what are the clinician goals. So obviously patients would like to see consistent quality care delivered to improve the success of their treatment, some where they have access to cutting edge cancer care or indeed care in any specialty, as well as timely treatment. And from the clinician's perspective, it's anything that can reduce the variability in treatment quality and consistency to maximize the same treatment success. Equally, in tandem with what patients would like, to be able to deliver cutting-edge cancer care at scale, and also provide this timely care independent of all these challenging resource environments. So the reason we are certainly relying more and more on artificial intelligence is because they are complementary to what humans are very good at. So humans are very good at common sense, dilemmas, moral questions. We have the ability to be compassionate. We have imagination. We're capable of generalization. Whereas AI systems excel at natural language processing, pattern identification, locating knowledge, anything that's repetitive, that includes things like machine learning, which I talked about earlier on, reducing the amount of bias, as well as an endless capacity to churn through data. And where are we now? So this is probably the most important. So if you take anything from my talk, I'd like you to focus on this one. So the use of artificial intelligence in oncology, if I were to focus on that, could be broadly classified into these different points that I've laid out here. So in diagnosis, so we have clinical decision support. We have the role of artificial intelligence in screening through imaging, through pathology. Image recognition, for example, is one class of AI that has been applied successfully to imaging-based clinical diagnosis, such as detection of melanomas in dermoscopy, retinopathy in diabetic patients, if you think about a non-oncology experience, and tumor detection for chest X-rays, mammographies, CTs, and MRIs. And we're doing some very exciting work, some of which I unfortunately am not able to divulge within Watson Health, and indeed many other wonderful technologically based companies. In cancer, another challenge that is ripe for is the augmentation of human capacities to understand and consistently apply these increasingly sophisticated knowledge for clinical decision making, and incorporate these increasingly diverse and complex patient data for personalization of care. And then we come to genomics, which again, at Watson Health, we've been exceedingly and very excitingly involved with. So also in clinical trials matching. So all these would serve to, if you will, take away a lot of the repetitive tasks, identifying actionable mutations, helping the research nurse, helping clinical trials units identify, screen, and actually warn the research nurse if there is anything that requires further action from their end. We're looking at EMR integration and smarter pathways, anything that can improve, automate, and reduce error, and ultimately improve the patient as well as the treatment journey. There are other aspects here that includes things like treatment planning and radiotherapy. So I'm a consultant clinical oncologist by background. And one of the things that we do is contouring on imaging models. So on images rather. So treatment planning will certainly help. And some of the work that other companies like Elekta are doing is fascinating, and it would take away a lot of time, if you will, save a lot of time for us, for the radiographers, in order to deliver better and more efficient quality care. I talked about tumor boards, so anything that can speed up the process there, treatment decision support and second opinion service. Look, I know we're all, when we talk about oncologists or physicians, we're all very experienced. So all this will only serve to help, not to replace us as practicing clinicians. And ultimately, in terms of the final treatment delivery and verification as well. So again, I'd like to sort of conclude by talking about what the future of AI in oncology and medicine look like. So ultimately, certainly for cancer care, what we would like to see is personalized treatment, which is associated with patient and cancer characteristics, practice value-based care instead of volume-based medicine. I would like to think that AI will lead the way to support the clinicians with a more clinical sort of input and provide high quality care, optimize the care pathway, harmonize cancer care globally, as I alluded to earlier on. Global health is very important, as well as ultimately a combination, a collaborative effort between humans and all these technological platforms. We must remember that when we talk about technology, we have to ask ourselves 4 questions. How reliable is it? How secure it is? How safe it is? And finally, and not least, how expensive it is. There are implications on data confidentiality, on ethics, on safety ultimately, and we have to factor that in when we consider anything that is new and novel. So what are the challenges and concerns regarding digital transformation of healthcare? I think AI and neurosciences need to be more synergy. It is less about explainability of a solution and more about interpretability, if that makes sense. And I think AI needs to be in the hands, in the minds and hands of many. We need to make it ubiquitous, accessible to everybody across the world. So it does require a lot of collaboration across industry, across academia. It requires expertise from both the clinical and the technological domains. However, it is important that such collaboration be defined as clinical leading rather than technical leading, because the technical and clinical perspectives might not always agree. So really a lot of interesting and smart AI tools. So I like to, rather than calling it artificial intelligence in oncology, I alluded to this before, I'd like to think about it as augmented intelligence, something that helps us as clinicians. So again, if I were to do a poll, I would have liked to circle back to my earlier question and for a show of hands on how many still feel that artificial intelligence and technology will be useful for our clinical practice, and how many of us will feel that, that such technologies are going to make us obsolete, or indeed actually going to be helping us. So I think we as physicians and surgeons need to sort of evolve and recognize it, embrace it, and ultimately work with it. So in closing, I'd like to sort of finish with another couple of slides by talking about how ubiquitous this is in general practice, as well as in the wider community. This is just a screenshot of a conversation that we had in our school group, which comprises not just doctors, but people from various walks of life. And you can see that there is an acceptance and an understanding that this is here to stay. And finally, I think, again, it's all about our patients. So this is a 94-year-old gentleman I recently treated for metastatic BRAF wild-type melanoma. They all have individual stories. And the reason I brought him up is just to say that we are indebted, or the whole focus of our attention when we talk about all these snazzy technologies and wonderful techniques is the fact that they all carry individual stories, and that is what we're ultimately doing. So I'd like to finish by thanking my brilliant team at IBM Watson Health, my colleagues, my clinical colleagues at Mount Vernon Cancer Center, and of course my peers at the World Health Organization. Thank you very much.